the second lecture, and it will be a symposium lecture with Professor James Cummings. He's an Emerite Professor of Pediatric and Bioethics at the Albany Medical College in the upstate New York. Dr. Cummings serves as the Vice Chairman of Pediatric and from 2012 to 2018. And he will give us a lecture. Can you put the lecture, please? Prof. James. Hi.
Good morning.
Good morning. So he will give a lecture about natural surfactant for respiratory distress syndrome. Prof. James, go ahead.
Okay, give me just a moment to get this up on the screen. Pardon me. Okay, I'm hoping that you all can see my slide. So good morning. My name is James Cummings, and I'm the Chief Medical Officer for ONI Biotech, manufacturer of Infisurf, a pulmonary surfactant for use in newborns. I want to thank you for the opportunity to speak with you today about natural surfactants for respiratory distress syndrome. During the next 15 to 20 minutes, I will discuss a variety of clinical surfactants derived from natural sources and what differentiates one modified natural surfactant from another. Are we okay? I see someone at the podium.
Okay.
We're good? Okay, thank you. So some general declarations. My presentation is supported by Hikma Pharmaceuticals, a commercial sponsor for your lovely conference. My only other declaration is that the material I present this morning is copyrighted, cannot be reproduced without permission. So throughout the world, there are many pulmonary surfactants being used in clinical settings, but they basically fall into two categories: modified natural or synthetic. Modified natural surfactants dominate the market and are likely to do so for the next several years. So I will focus the remainder of the talk on just those. With many surfactant products available, it's natural to ask whether one is better than the other, and if so, what really constitutes best? This is really not an easy question to answer because it depends on how one defines best. It reminds me of the ancient parable about 5 blind men being asked to define the true nature of an elephant. Each has a different answer depending on which part of the elephant they're touching. So taking a cue from these 5 blind men, I will explore the question of which surfactant is best by looking at it from 3 different aspects of pulmonary surfactants, specifically compositional, that is how they are made, biophysical, which is how they perform in the laboratory, and then clinical, that is how they perform in clinical practice in terms of efficacy and safety. So first, let's talk about how modified natural surfactants are made and how that affects their composition. There are basically 2 different manufacturing methods. Let's start with lung liquid extracts. There are 2 commonly used lung liquid extracts, Infisurf and something called BLESS, which stands for bovine lipid extract surfactant. Both are derived by lung lavage, which means they've washed out material from the lung of the animal. And both are processed in part, shown at the bottom of each of the slides here, by chloroform methanol extraction. However, there are some differences worth pointing out in between. While both are derived from cows, the bovine source, BLESS actually comes from adult cows, while Infisurf comes from newborn calves. In addition, while both extractions begin with a physical separation, Infisurf by spinning or centrifugation, and BLESS by simply scraping the foam off the top, BLESS also undergoes a chemical precipitation process prior to final extraction. These subtle differences in processing actually lead to measurable compositional differences. And here I will highlight 3 key differences. First is the amount of high density particles. What these are basically is material that contains the surface active components. Next is cholesterol, or so-called neutral lipid. This affects viscosity, which is important in terms of how easy the surfactant spreads within the lung. And then third, and perhaps most importantly, is a ratio of surfactant protein B to dipalmityl phosphatidylcholine, which is the major phospholipid in surfactant. Basically, the higher this ratio, the more effective the surfactant is, at least in the laboratory setting. And in all cases, when you look at these two different surfactants, Infisurf or Bless, you find that actually Infisurf has a much more optimal compositional profile than Bless, even though both come from cows and both at least start to be extracted in the same way. It gets more complicated when we look at the other way to manufacture surfactant, and these are from what are called lung tissue minces. In this case, we're talking about two surfactants commonly used throughout the world, Surfactant on the left and Curasurf on the right. Both come from adult animals, although Surfactant comes from cows, while Curasurf comes from pigs. Both involve taking the entire lung and mincing it up into a slurry from which surface active components are then extracted. For Surfactant, the extraction is fairly inefficient and chemicals actually have to be added back to make it functional. And Curasurf undergoes a much more complex gel extraction, which results in a better product at the end of the line. However, because both come from the entire lung tissue mince, we're not just talking about the lung lining liquid, but we're talking about all the structural components of the lung, including vessels and even cartilage to some extent. There's a lot of contamination from other cell materials. And so both Surfactant and Curasurf contain proteins, lipids, and other materials that are not present in native surfactant. And these materials can alter both the surfactant lipid and protein profiles, and in turn affect the actual performance, at least in the laboratory. I'm going to illustrate that in the next two slides. Here we have a simple graphic showing the lipid profiles of the various modified natural surfactant products on the right, the four I mentioned, Surfactant, Bless, Infisurf, and Curasurf, and natural animal surfactant on the left, which we'll just consider as the gold standard. One can see that DPPC, the key phospholipid in surfactant, shown here in a dark blue, is the most prominent phospholipid, of course, in all surfactants, and it's equally prominent in all these products. But if you look at the other colors of the smaller amounts of other lipids, you see the distribution of these surface active lipids, especially cholesterol, differs widely. And when you actually look and try to see which profile looks most like natural surfactant, when it comes to the lipid profile, apparently Infisurf really does look closest to natural surfactant compared to the other products. We also see something similar when we look at surfactant proteins. As you may already know, the key surfactant proteins are SPB and SPC. Now, SPB content, which again is critical for normal surfactant function, varies actually quite a bit among the modified natural products. But if you compare natural all the way on the right of the graphic, it seems to be closest to Infisurf. And other surfactants like Surfactant have actually very little surfactant protein B in them. Similarly, for surfactant protein C, again, they vary quite a bit from surfactant to surfactant product, but appear to mirror closest in Infisurf to natural. So we definitely see differences in composition between the modified products, but we can ask ourselves, do these differences translate to functional differences? To answer this question in the laboratory, generally people look at two key features of an exogenous surfactant, something called potency and the other called resistance to inhibition, both of which relate to a surfactant's ability to lower surface tension and then maintain low surface tension in a clinical setting. Exogenous surfactants have different living phospholipid and protein makeups, as I already pointed out. Although the phosphatidylcholine percents are somewhat similar, the remaining smaller phospholipids differ, as I showed you previous slide. This graph plots surface tension versus phospholipid concentration. So basically, the lower you go on the y-axis, the closer you are to the bottom here, the more functional the surfactant. A surfactant's rate of absorption, a surfactant's rate of absorption and ability to reach near surface tension was observed at various concentrations of phospholipids shown on the x-axis. And here's how a couple of different surfactants compare. Just for the sake of simplicity, I'm just showing two surfactants here. I could superimpose others as well. I think this makes the point. At a very low phospholipid concentration, neither Infisurf nor Savannah is actually able to lower surface tension much at all. So they actually don't function very well if they're very, very diluted. And as you increase the phospholipid concentration, both surfactants do somewhat better, but you can see that Infisurf reaches minimal surface tension rapidly, whereas Surfactant never quite gets down to minimal surface tension, even if you increase the phospholipid concentration more so. So at least in terms of this type of assay, one would say that Infisurf is biophysically more potent than Surfactant. Another way to evaluate surfactants is how they resist inhibition. In this slide, we plot both adsorption on the left, which is a measure of how rapidly surface tension is reduced, and on the right, the minimal surface tension reached, which is what we showed in the previous slide. But in this case, rather than plot against phospholipid concentration, we're plotting against hemoglobin concentration as a potential contaminant in the alveolar space. Hemoglobin, as you know, is a native protein, and it can be found in the newborn's lung liquid. But what's important about it is, like any other native protein, it can inhibit surfactant function. Since the ability to resist inhibition is a function of the surfactant's protein content, and since we know the protein content varies from one surfactant to another, we might expect to see differences between inhibition. And indeed, that's what we see. At increasing hemoglobin concentrations, both adsorption on the left and minimal surface tension on the right are adversely affected for Surfactant, but apparently not for Infisurf. So as you increase the hemoglobin concentration, you see Surfactant's ability to lower surface tension actually degrades, but Infisurf remains relatively stable and minimal surface tension is reached. Again, Infisurf with a more natural lipid profile and protein profile is more resistant to inhibition. So we see the potential clinical advantages of maintaining a lipid and protein profile closer to natural surfactant. You have a surfactant that has higher potency, that it can lower dynamic and surface viscosity. It has a greater resistance to protein inhibition. And by having a more natural ratio of surfactant proteins to active surface active phospholipids, you get rapid lowering of surface tension and rapid improvement of respiratory function, at least in theory. But the truth is, we really have to think about how does this translate to clinical practice? And this is the last question I'll address this morning. So we see that there are compositional biophysical differences, but do these translate to measurable differences in the clinical performance when we treat patients with RDS? Now, for this short talk this morning, I don't possibly have enough time to summarize literally hundreds of clinical studies of surfactants, but it's interesting to point out that among that large collection of studies, there are relatively few that compare two or more surfactants to each other. Typically, they compare surfactant to a placebo or a non-surfactant or a usual care treatment. But even of the handful of surfactant comparison studies we have, most are troubled by small sample sizes, poor design, or inconsistent results. And while you may hear a particular study that shows some dramatic difference between one surfactant and another, if you look further, you'll find a study that shows sometimes quite the opposite. And you really must look at the entirety of the data, not just one or two hand-picked studies. And this is what the Cochrane database systematic reviews and people like Dr. Saul and others have helped us evaluate the complexity of clinical information by combining studies and increasing statistical power in the analysis. They look at all the available data. And the conclusions they drew back in 2015 regarding modified natural surfactants are really still true today. All clinically available surfactants improve oxygenation, all facilitate weaning from the ventilator, all reduce death from respiratory distress syndrome, and none reduce the incidence of chronic lung disease. So if one were to summarize the clinical data that's available, and again, there is a lot of clinical data, no surfactant has been clearly demonstrated to be clinically more effective for the treatment of respiratory distress syndrome. I mean, despite what you may hear from one company or the other, when you look at the entirety of the data, you have to conclude that there's really no obvious clinical differences between surfactant products. So that leaves us with the other side of the coin, which is, okay, well, if they're equally efficacious, is there maybe a difference in safety profile? And again, some manufacturers have promoted their surfactants based on safety profiles. But the truth is, if you go back and look at, in a systematic way, at all the data that's available, and this is from actually the same Cochrane database, you find that there really are no differences in major complications reported with surfactant administration. That it seems to have to do more with the fragility of the baby or the mechanism or administration method that's being used to give the surfactant, but not the surfactant per se. So to conclude then, from a clinical point of view, systematic reviews and large multi-center trials have shown no differences in outcomes based on the type of surfactant used. So now we're left with another question. We know that there are clear compositional and biophysical differences. So in the laboratory and under chemical analysis, we see differences in surfactants, but those differences don't appear to translate when we do clinical studies. And you can ask yourself, well, why is that true? And there are, again, we don't have a lot of time to talk about this today, but there are many, many reasons that this could be true. For example, we all know that clinical studies are all limited in some aspect. You can never really do a perfect clinical study. That patients vary quite widely in the spectrum of their disease and also underlying risk factors or complicating factors, making it very difficult to compare patient to patient. And there are many other factors that determine neonatal outcome, even respiratory outcome, other than just surfactant deficiency. As previous speakers have talked about, subtle differences in the way you give them respiratory support can have dramatic differences in how they do. And so it's probably true that given all these other issues that are going on clinically, that compositional biophysical differences among commercial products, surfactant products, may not actually be very important in treating what I would call routine RDS, okay? But I would like to spend or talk in the last couple of minutes about a couple of recent cases of newborn respiratory insufficiency, which were not due to routine RDS, because I think if you broaden your look at where surfactants may be helpful in the clinical arena, you start to think about lung function in general and all the different conditions that we deal with in the neonatal intensive care unit besides RDS, or the ones that complicate RDS. Because I think these situations are not just common, but they suggest that the differences we see in the laboratory between surfactants may actually play out in terms of clinical advantages for certain kinds of conditions other than routine RDS. So the first case I want to mention is just one of meconium aspiration. So we don't think about, surfactant in terms of term babies, but just bear with me for a moment. This was a 38-week gestation male infant. There was fetal distress and the baby was delivered through thick meconium. The child developed immediate respiratory distress, was intubated by 30 minutes of age. The chest system was, and by an hour of age, the child was on 100% oxygen at very high airway pressures. An echocardiogram done shortly after the child was stabilized showed mild pulmonary hypertension. So they started nitric oxide, but there was no improvement. At several hours of age, out of desperation more than anything else, we tried a dose of surfactant. The child actually tolerated it quite well, And within an hour, we were able to wean the oxygen down to less than 40%. And this child with severe Meconium aspiration syndrome and pulmonary hypertension was extubated on the third day and subsequently did quite well. Another case was that of pneumonia, or perhaps sepsis. Again, a term baby. This was a 39-week gestation female infant. Mom was positive for group B strep. Her membranes had been ruptured for more than 18 hours. The infant appeared vigorous and well at birth, but quickly decompensated 24 hours. And by 12 hours of age, the child had significant respiratory distress, hypotension, was placed on mechanical ventilator, and the chest x-ray was a complete classic whiteout. This child was in Florida respiratory failure by the end of the first day, requiring 100% oxygen and very high mean airway pressure. Again, with really nothing else to treat the child with, the child had reached sort of the maximum of the respiratory support parameters we had. We gave the child some surfactant, actually a little bit less than a normal dose. And this child, again, like the previous child, within an hour, this child weaned significantly and subsequently did quite well. So in summary, modified natural surfactants are not made the same. The differences in lipid and protein, differences in lipid and protein composition result from the fact that they come from different sources that process differently, and they are purified or amplified differently. These differences in composition also seem to predict differences in biophysical characteristics. So how you test them in a laboratory setting or even in controlled situations in animal models, which I didn't have time to show. However, despite these obvious differences preclinical, we don't really see clear differences in the clinical arena in terms of efficacy or safety. However, despite that, it's important, I think, to point out that Infisurf is most like natural surfactant. And why do I emphasize that? Well, the analogy I draw, and by being closest to natural, by the way, we're talking about surfactants that not only have a rapid onset of action, but actually may be important across a whole spectrum of respiratory disease. But I emphasize natural because the analogy I draw is that to formula feeding versus breast milk. When it comes to picking a surfactant for clinical use, we are faced with many choices. And the approach that I take, and I have taken for more than 30 years or so, is the same as I take when I'm feeding a baby. We all know that mother's own breast milk is the best source of nutrition for babies, but not all babies can receive their mother's milk. So when you're looking for an adequate substitute for mother's milk, how do you pick one? Well, the formula companies have jumped ahead of us on that. And if you look at their promotional literature, they will continue to tell you which formula or what aspect of their formula is closest to breast milk. Again, breast milk being the gold standard. And I look at surfactants the same way. I say natural surfactant from the animal itself is the gold standard. And when looking at commercial products, I ask myself, well, which modified natural product looks and acts most like natural surfactant? So that concludes my talk. I want to thank you for your time and attention. And again, good morning and thank you very much. Shukran.